Thank you. Okay. So I just put together some guiding questions because I really want to try to get through everybody's engagement plans if we can. But these are, I've already gone through them. And these are some of the, some of the things I wanted you all to think about as we're talking through your plans. What have you done so far? What can you do to expand the engagement? What kind of barriers have you experienced? And do you really feel like you have that meaningful engagement that we talked about? And so, hate to put Katie on the spot, but I had a meeting with Katie this morning and her mentor, and she had a really, I would say initially, difficult project to think about where to engage patients and families. And I think that she came up with a beautiful plan. And I thought that we could start just by her talking about how you can take something that you think is very clinician driven and really involve the engagement and how that engagement can help move that project forward. So Katie, do you mind like a minute or two just?
Yeah, definitely. Okay. Sure. So just to briefly start to summarize my project. So basically we came up with an algorithm for collection of respiratory cultures from intubated and patients with tracheostomy tubes in the ICU setting. Essentially the diagnostic tests, without getting into too much details, has really sort of marginally poor performance characteristics, especially when it's sent in inappropriate clinical settings. The results often come back positive and can lead to inappropriate antibiotic prescribing. So the goal of the project was to develop and implement a protocol that would reduce the collection of what we're terming non-informative cultures, meaning cultures that are collected from patients unlikely to have a respiratory infection based on their clinical presentation, so that we don't drive antibiotic use in that setting. So we've done a lot with education of our clinicians. We've done a lot to understand the situations in which the test is being collected now, but we had not done a lot related to the families of patients who were having these tests sent. And as Amy said, a lot of the aspects of our project is really a provider level behavioral intervention, but as we learned 2 weeks ago and through stepping through some of the online modules through the FIRES program, I think it's important to have at least the perspective of family inform the education and approach that the clinicians will take to rolling out this initiative. And that was really the crux of our discussion this morning. And so we came up with a plan where we will engage somewhere between 2 and 4 parents of medically complex kids, maybe not kids with tracheostomies, but kids who are complicated in the hospital a lot, and understand a little bit about their stories and their impressions of diagnostic tests and the way that those things are kind of implemented in the healthcare setting. And then for those parents who have kids with trachs, kind of talk through some of the specific scenarios that they may have encountered. And again, the goal is to use that to inform our education for our providers. We also hope to have them review some kind of talking points that we put together for our clinicians, for families who may have questions about possible perceived changes in practice. The other thing that became apparent as we were sort of thinking about this question of family engagement and how, to Amy's second question, what can you do to expand engagement? We recognized that we actually really didn't understand how these families think about diagnostic test utilization, and in particular use of pathways or algorithms. I think many families may think like, oh, my kid is unique, why are you putting them on a pathway or an algorithm, and trying to just like kind of bucket them in that way instead of thinking about them as an individual. And we realized we don't actually know very much about the way families might perceive that in this patient population. And then finally, and more broadly, we hope to get a better kind of sense of how families view what is important to families about antimicrobial stewardship and what are their priorities related to the use of antibiotics in the hospital. We obviously, or I, think that this diagnostic test stewardship is really important, but what actually do families care about when it comes to antibiotic use? And our hope was that that could, to some degree, of course, inform this project, but really provide like a good setup for future projects and future initiatives in this kind of population. So that was probably longer than a minute or two, and I apologize, but I just wanted to kind of give people the whole breadth of our conversation and kind of step through kind of the thought process and the way that we arrived at what we did after our conversation.
Thank you, Katie. No, that's great. And the reason why I wanted you to go first was really, this was a project, and I have to be honest with everybody here, that I was stumped on. I was telling Katie, I was trying to think through all weekend how she can include patients and families, that something is, that's number one, a test, and families might not even know is being done to their child. And so, as you can see, with what we came up with what Katie came up with, this could actually turn into a much larger project down the road. But there are very important points where parents need to weigh in on this project, for one, and then in the future for other projects that you may do. So just an example of how there's one that's hard to think of, where can you engage those patients and families, and there's always a way, there's always a spot to put them in.
Yeah, we were stumped too, so we really appreciate your help.
So if it's okay, is it okay if we go through, if I call out names and we go, I hate to put everybody on the spot, but I will, and we go through the, just very briefly, the questions, and I'll just go through in the order I have. Is that okay with everybody? Nodding heads. Okay. Okay. So, Theta. So what have you done so far in terms of engagement?
I actually really appreciate Katie going first and giving the lay of the land. So my overall project has been on use of guidelines of care for infant nutrition for infants who have cystic fibrosis. And I've done a lot of work with regards to clinician engagement and how clinicians see the guidelines. And I had built in my original proposal an aim to interview different care team members as part of the multidisciplinary care team to get their perspectives, with the intention that I wanted to engage patients and to engage the caregivers and the family members to understand their perspectives as part of this. But it was future more than like I couldn't quite figure out how to wrap my head around that body. This is, I think, separate from the fact that as part of the space that I work in, like I feel that art has very active and engaged parents constantly, with a push from both a larger foundation of people, including a network that's built in right now that has leadership from parents as part of the initiative to engage. So there's plenty of sources I feel like I can engage and ask opinions, and not just opinions, but actually so as part of as an example, locally on our improvement team, we have parent partners as part of every part of our initiative work. And so we get input all the time with regards to our day-to-day improvement activities. And then on a larger scale, we interface in a group of improvement teams who all have embedded patient and family partners. And then those people are led in this larger network, in the learning network with parent and improvement partners. So there's a structure that lends itself to do this work, but the focus of the network has not been on my particular project in terms of nutrition interventions per se. It just is, it's the source in which to engage all these teams and ask some of these questions as a whole. So my approach was actually going to start with the leadership of the learning network as a whole, because there's and start with that kind of engagement, because I have my local team that I can ask, but I actually was thinking on a broader scale to inform the view of, and to me it's more than guidelines, it's actually the strategies that seem to work for how we manage infant nutrition for some of these outcomes. So their input on that experience, because ultimately it would be, what I'd like to do is inform some kind of care bundle or some kind of, like, this is how we all should approach as centers, as teams, the management of nutrition as a whole.
So I think that sounds like you have a great built-in team that's ready to go. When you had said, quick question for you, when you had said, look, you've locally been using your family partners in your local site, is this as you engage with some of the other sites, are there other families like within that network?
So yes, so both within locally, we have our longstanding parent advisory board within our CF program as a whole. But I think the shift has happened that instead of just having an advisory board, with our work within the larger learning network, we've actually brought our parent partners into more of a leadership role. And so they've had more of this has been like a working relationship over the last, I think evolved over the last 3 years or so, where we've had, we actually trained we've had some turnover now, about 2 or 3 individuals. And it's been such a rewarding aspect, because every time we meet once a week, and every time we meet, we have a new discussion that brings forth, their opinion, and they revise all of our communications that are going out to families. Are like, whoa, too many words. I mean, this just happened. We just introduced a home spirometer, and so they were talking about what that looked like. And they were like, please don't do that. I was like, oh, we're done. It's going away. So I mean, it's been a very one time we were in a community. It's just anecdotal, but we were in a community conference, and one of our parent partners was teaching us how to facilitate meetings better, like led a session on facilitation. And we're like, oh my goodness, we have so much to learn from each other. And so again, I think it's just been a really evolving partnership over time, which has been fantastic.
That's great. So it sounds like everything is going really well. You meet once a week?
We meet once a week, but we have different bodies of work. So I don't want to, not all of it is, not actually, 99% of that work is the day-to-day operations of our center, but it's not necessarily focused on my particular research project. And so I do want to draw a line that I am cognizant of not overburdening the same individuals. And so I think when I'm looking at my local center, that's our day-to-day work, where if you're involved in our local center, then we want to focus on that work. But then when I'm talking about my research project, which I think is more towards tapping in on the larger network and that resource potentially based on their own interest and time and whatnot.
Yeah, and that's a really good distinction to make, to be, really focused on exactly what you want this group to do. It's almost like a subgroup of a larger group. And so they would, I mean, as I'm sure you know from working, with your local site, that they know their families, and they know, especially within a network, they know how they've given feedback in the past. So if they can even nominate other families, so that you don't, I hear what you're saying about overburdening them, but even possibly giving them the opportunity to nominate somebody.
Great, thank you.
So just as a thought, and really kind of make the distinction that this is for the specific project, so that they know that this is what they're going to be working with specifically on the nutrition piece.
Thank you.
Sure. Okay, Anita.
Thanks. Can you guys hear me?
Yeah.
Perfect. So as a reminder, I'm a pediatric hospitalist, and my focus has been on parental ACEs in the hospitalized setting. So far what I've done, actually prior to this grant, I was involved in a P-Corps grant that I was not the PI of, but was had some time to participate in, where we actually met with, it was about 8 academics and 8 community members through a nonprofit that we had worked with. So we had about 8 sessions over 6 months where we met with the community where they were at. and parents to understand what their concerns and their issues were and how to participate, either do community engaged research or community-based participatory research. But since my question was a little different and I wanted to focus on parents of hospitalized children, I used more of the community engaged approach, knowing that the research question was kind of more driven from my perspective, but still wanted to include experiences that parents have had. So what I've done with my K-12 specifically, in the second aim of the grant, a lot of the focus is just on parent feedback. So specifically, we're screening for not only ACEs, but other social determinants. And so we are engaging them in qualitative interviews to see how they cognitively understand and process some of the questions that we're asking. But in that process, I wanted to make sure they were engaged. So we used a community partner, one of the partners I met from that Peace Corps grant, to help us with recruitment of other families that we knew are difficult to kind of engage in. We thought using this community-based approach, it was a known to the community, so they would feel more comfortable in actually participating in the interviews. So right now we've engaged them in understanding what the tool looks like and giving us feedback on how to modify this screening tool. And then moving forward, we are hoping to engage them in like implementation of the tool. So now that we have some information on the questions and what that format looks like, how does it actually look like in a real world setting? In terms of barriers, we did anticipate one where once the parent that was helping us to recruit and find other parents was kind of tapped out, we had to shift and think about where were other ways we could recruit and making sure we were getting a diverse sample, of different parent participants. The other thing that was a great learning experience for me was actually meeting the parent partners where they were at. So we were really flexible. None of our interviews actually have, our first set had happened in the hospital. Now that we're recruiting from the hospital, we're doing that too. We just were trying to make sure that we were approaching the parent in a way that was accessible to her and didn't have any transportation barriers to getting to the site. So that meant going out of kind of our ivory towers and meeting the family where they were at. So that was one thing that I was pretty mindful of. We also established a memorandum of understanding early on, so expectations on what the parent partners would engage with. They also gave us feedback as we created flyers for the participation, what read well, what didn't make sense, and then how we would follow up with the results of our study, knowing that it wasn't going to be anything like, we changed this, we cured this disease, but more that this process was now going to be in place because of the feedback that they had provided to us. So I think those are kind of the few things that we've done early on, and we're hoping to engage more meaningfully. I was going to develop a multidisciplinary team once we implement the tool, and have a few parent partners engaged with that process. So that'll look a little bit different.
So that's wonderful. My question to you was, you had written originally ad hoc, and that's a lot more than ad hoc. You've been doing a lot of work. And you brought up a really important point in terms of engaging with the community. And how do you make sure that you work with your community partners to really cover all the different families who you want to partner with? So diversity in terms of socioeconomics, race, religion, gender, and relying on those community members is often really helpful. And just to reiterate that all of the pediatric sites, we talk about it all the time. It's not easy for every site because, as you could see, you need to meet them where they're at. And just meeting them where they're at, at least in my experience, has helped a lot. So I think that's really great that you're doing that, and that keep using those community connections, because that's who they're going to trust. So I hope that she's still not tapped out or that you found somebody else.
We were able to, COVID hit, and so we made some modifications, and now we're using Zoom to interview families while they're in the hospital, knowing Wi-Fi can be a barrier as well. We hope to re-engage with her on other aspects of the study. So it's just, we're kind of regrouping a little bit at this stage.
Yeah, and if she doesn't have anybody else, even going, back to the original group you worked with, can you suggest somebody else who's well connected in the community would be helpful?
Yeah, thank you.
So it was a lot more than ad hoc. That was great.
I had forgotten I had written that in there, so thanks.
Erica.
Sorry, I was on mute. So I spoke a little bit at the last meeting. So this will be relatively quick. My project is co-producing a psychosocial prenatal family-based intervention for families expecting a child with congenital heart disease with parent partners and clinicians. So we have parents participate at 2 levels. One is as parent partners, and we have 4 parent partners on our study team. And the challenges we've had there are really related more to, and I talked about this last time, diversity. And I think, we have 4 parent partners, 2 of which I'd worked with very closely in the past, and I think are very familiar with the role of parent partner. And, they've continued to be engaged, and it's been great. The other 2 were new to this role and were very enthusiastic and have kind of faded over time in terms of involvement. And I think part of that is that they just, I probably didn't do a good enough job of really explaining what the role really was. And I tried, but I didn't. I really liked the training that you provided because I think that it did a really nice job of doing that. And so I thought a lot about, what did I need to do up front to make it more clear kind of how this differed from the role of a participant, and really what the expectations were and what their role is for people that have never been in this role before. And so, I would love to talk more about that in terms of diversity, because I think I have found that it hasn't been hard for me to engage parents who've kind of served in an advisor role in some capacity in the past. But it seems like it's been hard to access folks that maybe haven't served in that role before and are coming from more, underrepresented backgrounds. We also have parents participating as participants, and they're the ones that are actually working with us to develop the intervention, whereas the parent partners are the ones that are helping us to, define our study questions and make decisions about the study, and also take the information that we learn from our parent participants to help us to develop the intervention. Diversity there has been great. We haven't had any challenges with diversity with our participants. It's really been more our parent partners. And I think, we took a lot of steps to get there in terms of, we have clinician collaborators across the 8 PedsNet sites who recruited, and we really did emphasize diversity there. And we're able to, obtain about 40% racial ethnic minorities. So our real challenge has been really more diversity in our parent partners and keeping people engaged who have not served in this role before. And it seems like probably did not expect it to maybe be the exact role that it ended up being. And again, I think that I just didn't do a good enough job of that. And I really am excited to ideally use that, the training that you provided to provide some of that context early on next time.
Yeah, and feel free to go through the PCORI training that they put out. It's a little bit, it's more of a didactic, so it's not as interactive. So you can, they can pick and choose and see which one they want to use. But this is, I think, I falter on this as well, to be honest with you, that sometimes if there's a big lag in between when we engage people and then we go off and we do our work and then we don't engage them again for a while, sometimes we lose track of them. I've been very guilty of that. I work with a lot of projects where it could be months before we need to bring them back in again. One thing that I found that has been helpful has been just to send out a quick email, just to say to them, hey, I haven't forgotten about you guys. Your feedback has been so valuable. Here's what we've done so far. Here's where we're going to need you as we move forward with the projects. Just a quick note to let them know that they're still part of the project. You didn't forget about them.
So I think with our study, we have study calls every 2 weeks throughout. The expectation is that everybody comes to at least one a month. And so it's, I think it's almost the opposite, where we, we have ongoing calls. There's a lot of emails, there's a lot of communication, but I suspect that it just got to be too much, or because the calls are the parent partners plus all the clinicians, it may have just been, all of the talk about jargon, on the training, it may just have ended up being just too much jargon, too much, we're talking about qualitative methods, and that maybe I needed to actually have calls separately with the parents and not with everyone together. And again, this hasn't been an issue with the parents that have done this before. Like we have, we have two very engaged parents who have been on all of our calls and very involved as partners. And we've had this challenge with the parents who are new to the role, who are from backgrounds that are not typically represented in parent partners, at least that in my prior studies. And we just need to figure out I just need to figure out how to do it better and to really prepare it better and really think about, do I need to have separate calls with the parents to check in and make sure that they're sort of, how they're feeling about things, rather than just assume that they can be in with the clinicians and just kind of go along with everything in the way that our other parent partners have been.
Now, and you just used the key word, which is assume. Always ask them, which is what you're going to do, which is a great idea. And Jeannie knows all too well that even the most savvy of all parents who participate on these calls, like the families you have who may give a lot of feedback and do a lot of things, they even sometimes will nod their heads yes, thinking that you do understand them, and some of them really don't. They just don't know how they can say, I don't really understand this. One of the methods that Jeannie has really helped me with PedsNet is that anytime we would have a meeting beforehand, the steering board meeting, and there was information on there that was so jargony and I did not understand, was to offer me time to go through some of the stuff with her and do some pre-work so that I could have a little bit of basis of understanding before I got on the call. So that might be something else, but going back and asking them what will help them is what will really get your buy-in.
That's really helpful. Thank you.
Stephanie. Oh, and actually, I should probably start with saying, because I did read everybody's, and everybody's overall there's really, your parent engagement is a strength, and so this is just to kind of help you tweak them a little bit. One of my questions for you, Stephanie, as you're going through this is, do the families who you've engaged, do they meet as an advisory group or do they meet with the larger study team?
Yeah, sure. Can you guys hear me?
Mm-hmm.
Perfect. So my project, just very briefly, I'm a neonatologist and really interested in parental experience for families that live at great distances to the NICU. And so we've done a couple of things. We are in the process of a series of qualitative interviews, really trying to understand kind of the lived experience of families who are living at great distance. And that's been really informative, has changed over the last really quarter as COVID has sort of evolved. And so a lot of the themes that have come out of those interviews have been specific to some of the barriers that I think we knew existed that have just been amplified by our current state and visitor restrictions and all of the other changes that families have experienced. And so that's been really fascinating. We're in the process now of sort of kind of grouping those interviews and then hopefully kind of feeding them back to our parent partners to sort of figure out what our next steps are and how do we then take this information and move forward with some interventions that help reduce some of the disparities that families are experiencing. We've also partnered with Special Kids Special Care, which is a group here in Denver that so far has really been focused on the transition from NICU to home for metro area families. And so trying to start the conversation with how do we expand those services because they are so well connected in the community to really help serve families as they're leaving and going home that's not within the well-resourced metro area of Denver. And sorry, Amy, can you repeat your question that you asked right before I started? I've since forgotten it.
Sure. No, so I just noted that, your parent engagement there, it was really good and it was a strength. And my only question was, do they meet separately as an advisory group or are they part of the team?
Yeah, so right now, I would say that that's one of the struggles that I'm having. I had a great sort of family or parent partner that was separate from our larger advisory group, who started with this project as I was developing it, over a year and a half ago now. And just in the last 3 or 4 months, she has sort of stepped back for a variety of personal reasons. And now I'm sort of at this crossroads. So I'm actually really taking a lot of notes today to try to figure out, where do I go from here? Do I try to tap back into the larger NICU parent advisory group, which honestly, I think has some of the same challenges that Erica was mentioning, with lack of diversity, and in general has really been a local group? Or do I reach back out and try to connect with families that really are living the experience of being far away from the hospital? I think one of the challenges that it's not necessarily unique to the NICU, but I'm coming across is, once people leave the NICU, a lot of people don't want to think about it. They don't want to go back. They hope that it's a one-time, experience for their family, and not that they'll sort of, it's not a place that you generally spend a lot of time once you've been discharged, unless you have another child there. And so trying to figure out when is the right time. I know that, there's a lot of discussion that probably in the first 6 months after discharge is not the right time. But also, once families get far enough out from their NICU experience, it's not necessarily something that they're kind of wanting to kind of relive and come back to. So that's one of the challenges I'm figuring right now, is how do I reach back out to families that are of the right sort of group to be tapping into, and then what's the right time?
And so I will go back to your families in the NICU, your family partners who are already in the NICU, and ask them.
Yeah.
They'll have at least some information for you. They'll at least be able to tell you, look, for me, I couldn't even talk about the NICU for 6 months when I was out of there. So they'll bring you that valuable information. Also, what's been helpful in terms of, I know at least CHOP, and especially in the NICU, we really rely on our social workers in the NICU. So a lot of them have really good relationships with the families and know them well. And they have oftentimes nominated some of our best family partners.
Yeah, that's a great source. Yeah, them and our chaplain, I think, and our child life group are probably the 3 ancillary groups that have the most connection to some of our families.
Absolutely. And they'll also be able to help you with that question in terms of how soon do they want to be contacted. They'll have a lot of that information.
Okay.
So that's where I would start.
Thank you.
Sure. Amy.
Can you hear me?
I can, and actually, my question to you is, before you go through it, is, do you have an advisory group, or do you have one parent who is participating?
We have a mixture of both. We have a few parents who are highly engaged with kind of study design and execution decisions, and have helped us immensely throughout all phases of the project. And then I'm very fortunate to have a research mentor, Lori Crosby at Cincinnati, who has actually been the director of the Family and Community Engagement core of their Translational Research Center for many years. And so this is right in her wheelhouse. And so she's taught me a lot about patient and family engagement, and has access to kind of a larger advisory group that we've used for kind of less frequently, but that we've used to kind of engage more diverse perspectives. Similar to Erica, the primary barrier that I found is that we've had a few caregivers who have been incredibly engaged through all phases of the work, and I agree with Erica that I didn't do a great job of outlining clear expectations, because a lot of patient and family engagement in research was new to me when I started this work. But thinking about sickle cell disease specifically, it impacts primarily Black and Hispanic individuals, many of whom live in poverty or have other psychosocial stressors, which have only intensified during the COVID-19 pandemic. So it's been really challenging to figure out, how do you engage those patients and families who have the most barriers to care, who are really the ones that we're most interested in hearing input from. given kind of the topic of my work. I've been thinking a lot about how do we offer kind of more flexibility in terms of not just times that we meet and things like that, but also roles that we can offer. So maybe for some families it's really not feasible to say, I'm going to commit to being a research partner for you for 2 years, but maybe there's an aspect of the project that they feel really passionate about, or a time frame that works for them better. Like, I can't commit to anything the next 3 months, but reach back out to me. So we've been trying to think more creatively about when we approach these families who have, and parents who have much more on their plate in terms of barriers to even accessing routine healthcare, let alone participating as research partners. How do we kind of be creative and flexible about our expectations and also our opportunities for them to be involved? And I really appreciated the fireworks training, because it made me think about some of the other aspects that I hadn't considered. Like, we do compensate our family research partners, but I hadn't thought about things like childcare and we think about that for our research participants, but for some reason it hadn't crossed my mind to think about that for our research partners. And I wonder if having some of those options and compensation and resources up front might make people more willing to participate in this kind of new role that they're a bit unfamiliar with. So that's a lot of what the barriers that I've experienced and what we've been kind of thinking about for how to, in the next kind of phases of the work, how to overcome some of those. But I'm interested in other ideas or input.
So your ideas are really spot on in terms of asking them what's best for them. I've had family partners who, with all good intentions, have tried to like dial into a meeting, and for some reason something happens. One year her son kept getting admitted to the hospital, and so it's really meeting them where they're at. And when you find that you do have somebody like that and they really do want to participate, is to go back and ask them, what's the best way? Your voice is so critical. What's the best way for me to get it from you? Should I call you individually? Would you rather do it in an email? Would you, understanding that they might not be able to attend all the meetings with everybody else, but how is best to gather their feedback? But thinking of keeping it sounds like you need a very wide variety of ways for them to connect, which is usually the case with any family partner, no matter what their socioeconomic status is. Life is busy and hard. So meeting them where they're at, and even if you have somebody who really wants to do it but is having a hard time, saying, look, thinking about carving out those parts in the project where it might be doable for them, and not overwhelm them is also, and also acknowledging, you said something really important there too, in terms of the compensation. So we are used to compensating our research participants, but we're looking at them in a whole nother way. So I always like to explain to them too that their role is really valuable, and while they're not a participant in the research, they are a consultant, an expert. And so really kind of emphasizing with them that they are a family partner and their role is just as important as the other consultants that are on the team, whether it's a statistician or somebody else weighing in, but to really emphasize that with them.
Can I ask a quick question? I really like this idea of like us being much more flexible with how we define the role of a parent partner, because I think I've been coming at it, more like, okay, this is the role of a parent partner, and it's really important that they're part of all the calls so that they're sort of equal in the team, but realizing that that's really not going to work for everybody. And some of the challenges that I know I've talked about and others have talked about as well. So I really like that a lot, and really leaving it up to the parent as to how they think that they can really contribute. But then that's another question for me of what comes back with compensation. So how do you determine compensation? Because in our plan, we wrote, this is what each parent would get, but there's some parents that are much more involved in like regularly scheduled meetings than other parents. Do they get the same amount? Because really in the end, like they're serving in the role of a parent partner and this is the stipend, or is it by the hour that they participate? But how do you really quantify that? I would love to hear your thoughts on that.
So that's a great question. I think that definitely, I mean, my fallback is always no less than 25 an hour for anybody. And I think that that's going to be, if you do it hourly, then the person who's going to be contributing more is naturally going to get more money. That's one way to look at it. You could work in a higher hourly amount for them because they are meeting more frequently, but perhaps even thinking about them in other roles that would quantify that. So maybe they are a research family partner, but are they also a co-op in the project? So would that be something that's an option to offer to them?
Yeah.
Amy, I just want to Kate, I'll just quickly inject because I've done this a bunch of times. Amy really did hit the nail on the head. I will say that the hourly rate, Amy, we have been boosting that a bit because just a lot of guidance and feedback from both PCORI and parents. So in this latest grant I'm writing right now, we put in $50 per hour for a parent. That would go an hour meeting. We expect an hour prep time. So per meeting would be $100. And so they bill basically as a consultant. That's for your parent partners. But I think it's really valuable to have a member or two or three parents on the research team. This maybe not so much for your projects because they're a bit smaller, but as you guys begin to write out your independent K awards or RU awards, think about having a co-investigator as a parent. And then they should be compensated at about 10% effort to participate in the meetings, to engage, to be part of the dissemination team, and also perhaps to lead. So that's the way we've handled it, and I think it's gone well. The other thing we've done is we've done youth stipends with the same kind of approach, where the youth get $25 an hour, which for many youth is it's a fair bit of money, but we're trying to be respectful of their time. What I think is not acceptable anymore is to just accept people that accept that they'll donate their time, because that's not part of their job. And so we really want to be fair and show that we respect their time and do that with some level of compensation.
So it's acceptable though, so for example, like I had told the parents in advance sort of what the stipend was, but some have participated a lot less than sort of what was in that. So do I just pay them less and say these were the number of hours? It gets awkward. I think I should have done a better job of like specifying in the advance.
Yeah.
Do you know what I mean?
Yeah, you don't want to. Yeah, I think you have to honor whatever you said up front, but recognize going forward that you should, the money thing, you always really want to be sure you are quite clear on it from the get-go. And I think people should bill for the work that they've done. They really are operating as consultants, unless they are a formal co-investigator, in which case a stipend or a percent effort type thing, a stipend would be the way to go.
But just setting a stipend in the beginning is not a good idea, because if someone doesn't participate to the level that was sort of
exactly.
That's sort of my situation. There's 2 parents that have and 2 that haven't, and I'm not sure how to handle it.
By the way, it's the same with your.
Can I ask about the? Sorry.
Okay, go ahead. Nope, go ahead.
I just had a question about sorry, this is somewhat, not quite on topic in the setting of what's there's a investment with regards to building up this collaborative relationship and partnership together. So, but is there a critical, I mean, is it, you put all one within a co-investigator as part of that relationship? Should you have 2? Should you have 3, 4? I mean, what's the number that you should be cultivating kind of consistently to feed the research program?
Well, so I would just say, so I thank you, Chris. And actually, I want to join some of your grants. $50 is great an hour, and I'm so glad to hear that PCORI is recognized and it's going up. I do think a couple of things before I answer that. One thing that does really help, that Chris brought this up, is having them as a consultant on your project. So that now again, it may differ per institution. So some institutions, it's harder for the research business office to do that. I know at least we've had a really good buy-in in terms of CHOP. It's a tedious process, but we take all of our research family partners who are on a team, they submit their W-9, they go through the process of getting a PO number, and they submit invoices. And so that, again, also makes them feel like a really valuable part of the team, and would also address the issue of the hours. And so I send along, and I can send it out. I have an hourly template I send them for them to keep track of their hours.
So it's John. So I agree with everything, especially focusing on hourly rate mostly, and having clear expectations at the beginning. I think you have to be careful about unintended consequences of thinking only about larger engagements. So great to have someone as 10% on your project, but that's a lot, and you're not going to be able to afford more than one, and then suddenly, or two if it's a very wealthy grant, and suddenly you only have one or two voices instead of maybe a more diverse group of voices who you need as an advisory board. And I'm thinking of racial and ethnic diversity and experience diversity and all of the other things. So I just think you need to be clear about where you can afford and where it's reasonable, where you need partners at 10% and where you need just like we have data safety monitoring boards, where you need an advisory group where you'll have the ability for people maybe with less time to provide input and inform the project along the way.
Yeah, and that's a really great point, John. And the other part about that's so important is that one parent. So even if they're, if you have them as a part of the team, that they're not alone. So usually two parents, they have each other, more parents on there. But Chris has oftentimes been, I've been the point for his engagement team, and then there's an advisory group under that person. So that's another way to think about it. So you have a point person who does the engagement that's part of the main team, and then an advisory council of parents that works with that person.
Amy, since we only have a couple minutes left, because I know we're only going to one today, could we try to get, I think we have, Suchitra hasn't gone, and I'm not sure if Corinna's on the line, but maybe we can squeeze them in.
Okay, sounds good.
Suchitra, do you want to go?
Oh, yeah, sure. So just a little bit of background about me. So I do pediatric infectious diseases and hospital medicine at Children's Hospital in Colorado. And my project focuses on trying to help develop ways to risk stratify people who have influenza to try and help determine which patients benefit from testing and therefore treatment, since there's really not a whole lot of guidance around really which populations we should be targeting. And so the K project was going to incorporate some stakeholder engagement, both in terms of people who are making some of those decisions, but also families, to try and help determine a local implementation plan to really yield the highest clinical impact. And so some of the work that I have done in the past overlaps a little bit with what the engagement would look like for this project. So last year, I was involved in a study where we wanted to evaluate the role of rapid diagnostic testing in folks who are presenting to an ED setting with respiratory illness. And so as part of that, we did get a lot of feedback from families. So we surveyed all the families of kids that were involved in the study to get a sense of how they felt about testing in that sort of setting, whether they would benefit or would appreciate a protocol-based assessment versus something that was very much driven by parents themselves, and just how they would feel about testing in general. And so there was definitely a wide variation of opinion in terms of people that were strong proponents of testing versus people who thought that that was kind of invasive and didn't necessarily want to go that route and really wanted to be guided by providers. So that sort of helped to inform a little bit about what types of questions that I'd want to ask this go around, and just see how they would be involved in this type of work. And so I'm sort of in the planning phases now of how to engage more families to get their perspectives for this work. So I've done a lot of stakeholder engagement with folks in our ED and hospital, so more provider perspectives. And so now I'm going to be focusing on getting some of those family and parent perspectives as well. So I thought it was interesting hearing Katie's perspective, because I think our project sort of is similar in that way of we're trying to help sort of drive decision making that's sort of evidence-based on a provider side, but really need to incorporate some of the family perspectives too. So I really appreciated, Amy, your session last time and this time as well. And I've been sort of taking notes on just how to go about that approach. So my thought was to reach out to the families that we had engaged who were interested in continuing to do research with me. So I've already got like a number of folks who are interested, and then just to kind of get some of their feedback and their perspectives, and then to just be also engaged with them as the project unfolds. So as we come up with what our strategy should be, getting feedback with that, and then just sort of updating them on what we're finding just as we're rolling out this project too.
Yeah, I think that sounds great, and I agree that the work sounds very similar to Katie's. And that was, parents, while we do in terms of testing, we always want to get the clinicians' feedback, because they're the ones who are going to order the test. But what about the family on the other end, who's maybe, and I used this example this morning with Katie, who's maybe seeing all these ads for get your child tested for, get yourself tested for flu so you can get on Tamiflu as quickly as possible and get better. What are some of those people thinking? They see all this media out there, and then it's one thing to get the clinician's viewpoint, but if you have a parent who doesn't know any better than just seeing some of what the commercials tell them or what they hear from other families, what's their thoughts about all of it? How do you go about educating them?
Absolutely, thanks.
And Corinna.
Corinna, I think you're muted still.
Okay, is that better?
Yes.
Okay. There were two different mute buttons. Sorry.
No, I was just going to say your engagement's phenomenal. So I love to hear about your meeting every 2 to 3 months.
Well, it hasn't actually. So the best laid plans, it hasn't actually worked out that way. And partly, so these last couple of weeks, listening to everybody's sort of successes and struggles with this has actually been very helpful, because I feel like this is part of my project that I thought I had a really good plan for, and then feel like it has sort of fallen apart. And part of that is because some of the preliminary data that we were collecting that was sort of laying the foundation for what we were going to do, which we had a lot of input from families on. I mean, the whole project really stemmed from families coming to us and saying, hey, this is a problem, can you help fix it? And so we had a couple of families who were very, very interested in this topic. So to remind everybody, I have been looking at how our pediatric oncology families utilize our patient portal, specifically for getting test results. And so the whole project started because there were some families who said, hey, this is a problem. I'm seeing things that are terrifying me, and can we do this a different way? And so so they were very involved in the early planning of it, and it was all sort of predicated on getting some data from this other source, and then figuring out how it fit with our families. And that data from the other source just hasn't really panned out the way that we thought it was, and it has taken a lot longer to figure that out. And so now we're sort of at a spot where I need to go back to those families who we've sort of lost a little bit of touch with because there's a big gap, you know, while we were doing all this other stuff, to say, where should we go with this now? And so, yes, what I set out to do has certainly not happened. But this has all been really great information for how I can sort of regroup and refocus with them. So I'm stealing lots of ideas from everybody. And maybe it will bring my anxiety level down a little.
Well, so I would, you know, you're really in a good spot to be able to go back to them. I mean, well, first of all, we've all had COVID, so we've all kind of been scattered and been not doing our usual thing. But it's a good time to maybe check in on them. Hope you're staying safe and well. Hey, remember, you know, I know a lot of time has gone by. Here's what happened in the interim. Here's where I need your help. To just be very transparent with them, I think goes a long way. And they'll really feel like they want to participate even more because you didn't forget about them and you want their opinion moving forward in problem solving.
Yeah, I mean, and we have some very outspoken families, and so, you know, I hate going back to them and saying, gosh, I really feel like we effed this up. Like, now we need to sort of almost start from scratch again. But I think, if anything, they may be people who are like, ooh, well, let's do this instead. So we'll see how it pans out.
Yeah, transparency is always the best. And I think if you're asking them, being very transparent, saying, you know, that we didn't do this right the first time, having them help you build it will not only give them more of a buy-in to the project, but I think that you'll have a lot of really very passionate family partners. And so I know my time is up. I see Jeannie. I just wanted to real quick let you guys know the last slide, all that is just a link to the new PCORI training resources. Again, I haven't had the chance to go all the way through it. It's taught in a little bit of a different format than Fireworks, but what I've seen so far looks really good. So take a peek. And then if anybody has any questions, let me know.
Amy, thank you so much. I think your sessions were really great, so wonderful, and it was so helpful to, I think, hear from one another what we're doing, both what's going well and what's also been hard. So I really appreciate your time.
Can I also, sorry, just one more thing, chiming in. You guys are all doing a really great job. You know, you could tell that you're really passionate about making sure that you want to include that family voice. So hats off to you guys. It's not always easy.
Thank you so much, Amy. Thank you everyone for staying on, especially a little past the hour. And as I said, I'll send out a follow-up on the announcements that I mentioned, and just want to put a preview out. Our next online session is on September 21st, and Dr. Robert Kahn from Cincinnati will be joining us and talking about community-based learning health systems and equity. So we're excited about that. So until then, enjoy the summer, and thank you all so much. Bye-bye.